reaction.
This is Robert McMullen, MD, and I'm going to talk about depression in general and the two general types of depression. I've been doing psychopharmacology for over 30 years, treating people with all sorts of disorders, mainly with medication, although also with bright light therapy and a few other modalities. And now I also do TMS, transcranial magnetic stimulation. I went to Georgetown Medical School, and then I did my psychiatry residency at Columbia. Now, there's two basic types of depression: the typical depression and the atypical. And the atypical isn't that atypical, since about a third of people have it. But the classic typical depression, the person has symptoms of not being able to sleep, waking up at 3 or 4 in the morning and being unable to get back to sleep. Their appetite goes way down, and they may lose a lot of weight. They also cannot find anything that makes them feel better. If you tell them jokes, you can't jolly them into smiling very much less chuckle. And good things happening, like winning the lottery, they would just say, well, so what? I feel so miserable, I don't care whether I won or not. Going out to see friends, it doesn't lift their mood at all. Now, and then they have the other symptoms of depression, of low self-esteem, inability to concentrate. They're usually lethargic. It's very hard to do things. They hate themselves. They feel excessively guilty. They ruminate about the past. And they often have wishes to be dead. And that gets to be a little bit more serious when they're starting to have fantasies of how to kill themselves. Now, the other type of depression is characterized by having hypersomnia, sleeping too much, being unable to get up in the morning, just enormous struggle. They can often sleep 12, 14 hours or even more per day. Sometimes they'll sleep 12 or 14 hours at night and then sleep more hours during the day. And their appetite often goes up, and or they have a lot of carbohydrate craving and gain weight. Sometimes if the depression is really severe, more severe than their usual depression, their appetite will go down. They also have more mood reactivity. Often when they weren't depressed, they were more rejection sensitive than usual. So if they made a mistake, not a big mistake, and their teacher or their spouse or somebody they respect got a little angry at them. They made a small mistake and the other person has just got a little bit of anger at them. It'll ruin their day. They'll ruminate about it, they can't let it go, and it'll ruin their evening. If they have a big loss, like a big romantic disappointment, or fired from a job, or something like that, a big rejection, or what they perceive as a rejection, then they can go into quite a depression. They might go into a depression that lasts a few weeks or longer, and go to bed for 2 or 3 weeks. And then these atypicals have a mood that's more reactive to events. If you joke with them, somebody I saw today who's just profoundly depressed, and you would think she's the typical depression, but she has hypersomnia and some of the other symptoms. And when I joke with her and make little jokes about things, she ends up smiling and even chuckles from this profound depression. Those people are much more reactive. And if she were to go out with friends and spend some time with other people, her mood would probably lift during that time. And I tell people, even if it doesn't lift, it's not going to get any worse. And you got a chance that it'll make it a little better. It's deadly to be alone. It makes you depressed and keeps you depressed. You just can't live in an apartment by yourself and be depressed and then get out of it. You have to have friends. For millions of years, we've been like dogs. We live in a pack. We live with other people in little villages. And people didn't live in a little house by themselves. They always had their grandchildren and children or their cousins, or it was all the relatives would be in one structure. The only person that ever lived by themselves was a witch in the fairy tales. And then she's in a little house all by herself in the middle of the woods. And that's one of the reasons she's there, is because it's so unusual. Anyway, so these people with atypical depressions, they're often a little bit bipolar, or maybe you could say they're all a little bipolar, and all of us are a little bipolar. That we cycle in our moods. We have a few days or weeks where we're just a little more energetic and a little more optimistic, and then we have a few days or weeks when we're just a little bit more flat. But this range is just a little above normal, a little below normal, so it's not really a disorder. It's just a little bit of cycling. And then the difference with us that have mood disorders is that the amplitude of this cycling is bigger. The fellow who did the research, as I remember, on these cycles that we all have was a fellow named Eastwood, and I believe it was in Montreal. But he went around and interviewed people who had no history of mood disorder, and then had them keep a chart of their depression, their energy, their anxiety, and it turned out everybody was cycling, which was a surprise to some of them, because they could see that during the period when they hated their job and they kind of wanted to quit was during one of these down periods, and that these cycles were relatively regular. You know, they might be 2 or 3 weeks of being a little below normal, and it might be 4 weeks or 5. Yeah, but they were in weeks or days or months, and the people who cycled over months tended to be seasonal, worse in the winters. In any case, getting back to the two different types of depression, in the typical depressions, then the typical antidepressants often work well. The SSRIs, Prozac, Zoloft, and so on. And also Wellbutrin, bupropion, either by itself or in combination. And with the atypicals, it is interesting that many of these people are now wearing off of the SSRIs. Often you meet somebody who did very well on SSRIs for 5 years, 10 years, even 15 years, and then they pooped out and it no longer works. And then they try another one, and then they add Wellbutrin, and then they do this and that, and it doesn't work. And this is a major problem for us, because now there's treatment resistant to the medicines that always worked. And these people, probably more often than we do it, should switch to an MAO inhibitor, which a lot of doctors are a little cautious about using, because if you eat cheese, it can make your blood pressure really shoot up for a few hours, and then you have a risk of a stroke. However, it's dose related. If it's just a little bit of cheese mixed in with your salad dressing that's unlikely to give you much of a problem. And a golf ball sized cheddar cheese, maybe it wouldn't give you any problem at all, but if you eat something like the size of a softball, then you'd be in trouble. And you can carry around a sort of antidote, medication that will just suddenly reduce your blood pressure, and you can use that if you think you've eaten the wrong thing and your blood pressure might be up high. And another thing that these people should have is a small amount of lithium, maybe only 150 milligrams, and the TMS works well with any type of depression. And it also works well for obsessive compulsive symptoms and Parkinsonism and quite a variety of different neurological and psychiatric disorders, which we're just working on now. So anyway, that's my summary of depression, and it's really a deadly disease. I want to add one thing, that physicians have one of the highest suicide rates, and that's a little, puzzling. And we think part of it is because they feel a little invincible since they're a physician, and they're embarrassed about going to see a psychiatrist. And maybe that's because a lot of us psychiatrists are a little weird, and we wear loud ties. I usually have a loud tie on, and and some of us, not me, go to work in sandals, and they just don't seem like regular doctors. And that might be part of it. Or they just maybe don't want to admit that there's anything wrong with themselves. But it's a very high suicide rate. And also I was thinking that maybe part of it is because of the guilt associated with the work. If you make a mistake, somebody can die. Or they can get really ill, and then you think back, gosh, if I'd done this or that, this might not have happened. And often it's not really, it's a retrospectoscope. You're looking at it in retrospect, and you're thinking of what you could have done back then. But back then, anybody could have made the decision you made, and the fact that it turned out badly is not really anybody's fault. It's even worse when you do know it's your fault, though. And then if you're sort of in that type of depression that's atypical, where you react to events a lot, this can suddenly send you into a really severe depression. And maybe that's what happens with a lot of these people, that they commit suicide. I had an oncologist friend, and he just suddenly, mysteriously killed himself. And I find it, I really regret and find it surprising that he didn't really ask me about his tendency to depression. Maybe he didn't have it that often. He was very successful, very smart, and then just suddenly committed suicide. And same with Anthony Bourdain. And with Anthony Bourdain, I saw one thing that was a hint that he has depression. One of the other reporters asked him about his drug use days, which he's always been very open about, that he used heroin and other things in his younger years and getting off of drugs. And it sort of caught him by surprise, and he seemed to have a couple of tears in his eye. And he said, I think about it a lot. I think that I must have killed at least one Colombian by my drug use. Meaning all the money he spent on drugs that supported the whole illicit drug industry. But if you think about it, that's a little unusual. Most people that went through abusing drugs and then they got out of it, they felt that was part of the life, part of life, and part of what was going on back then. And they're grateful they're no longer having that problem. And also it's ruminating about the past, which is what people with depression do. And also it's not entirely logical, because with as much money as he was worth, he could easily take $30,000, $50,000 or more and go down to Columbia and donate it to a health clinic and save 10 lives this year, or 20 or 30. And somebody who ruminates like that about guilt from the past, that you could argue is not entirely logical, those people have depression. And it could be he was chronically mildly depressed, but an atypical depression, so that when he got himself going and he was doing a show, he would come up and he was animated and fine. But at other times he could sink, and then that day he really sank. And perhaps didn't really realize it was a disorder. Often when you feel badly and that you're not functioning like you should, and you feel guilty about things and you want to die, you feel, well, that's a reasonable decision, and you don't see it as an illness. Anyway.
Thank you very much, Doctor.